Good morning, everyone. Thank you very much for attending the APASU Oncology 2024 Kyoto, the Center of Hepatology. Now we would like to start the APASU postgraduate course. Now we start the first session, postgraduate course ACLF, chaired by Dr. Shiv K. Sarin, Dr. Ashok Chaudhary. Doctors, please.
Thank you. So now we are going to the first one ACLF. So the topic sequence wise, the first is the definitions, which will be by me. And then Professor Thira is going to tell on prognostic models and disease severity assessment. And the third one will be the lectures on newer managements in ACLF for 2024. And that's a video lecture by Professor Sarin. Okay, so with this, I am going to present. Thank you. Yeah, good morning. So, at the outset, thanks the team of Hustle, their kind efforts, and privileged to have this in the PG course. So, I think the most important is SLF wise definition of pathogenesis. So, I have been asked these three sequences, that is definition, pathogenesis, and the next part is going to be covered by Professor Thira. So, in following few minutes, we'll go for these sessions like this. So, dear friends, I think you know a acute insult to a liver. When happens, if it's normal liver, it is ALF. If it's cirrhosis or cirrhosis without CLD, they have a potential to develop ACLF. And those having prior decompensation or having persistent decompensation, they can be either acute decompensation or ACLF, and some progress to develop continuously a end-stage liver disease. This is what will come in following few slides how to clarify this. So this is the area of controversy which will cover the topics, whether this should be compensated only or there should be prior decompensation or they're having persistent decompensation. And once you get an acute insult, the course is like this. Either it is AD or it is an SLF as an index. Then they may get recovery, can come back to compensated, or they remain decompensated. Or they can get another acute insults or repeated insults, which can give them another episode of acute decompensation, or they get recovery, they get recompensation, or they progress. So this is in a nutshell what the liver disease present to us. And over the time, this person have three fates. Either they will recover, or they need a transplant, or they succumb to the illness. Those get recovered, either they will become compensated cirrhosis, they can develop fibrosis, or they can have a normal. So this is called as the reversal, either from advanced fibrosis or cirrhosis, reduction or persistence in the fibrosis or waiting normal is reversal, where if remaining in compensated state is recompensation. So dear friends, now we thought that it is an acute insult. Now we'll cover how the pathogenesis happens. You can see this is a concept of having the inducer. Inducer is an acute insult. The sensor is an the inflamed liver, and the mediators are the inflammatory products, the cytokine storms, and the response is surge or can develop cause. And this is how the cytokine storm milieu has led to the ACLF syndrome. So you can see the cornerstone of ACLF is immunodysregulation. You can see the macrophages, neutrophils, NK cells, CD4, T helper cells. They get in response to an acute insult, cytokine productions, T cell proliferations, and associated infections can be antiviral phagocytic dysfunctions and cytokine productions. All these keys to one mediators which can give rise to all the complications what we find in case of ACLF. So after getting immunodysfunctions, whether it is an infection or it is a non-infectious insult, it is the pathways of infection you can see here. it is the non-infectious. You can see here, the infection releases the PAMP, the non-infection releases the DAMP. And finally, there is a common cascade. And you can see this leads to the inflammatory response which goes on. And this is likely the common pathway, whether it is infectious or non-infectious. So dear friends, just want to suggest, this you can see are the insults we can see. The hepatic, it can be acute severe alcoholic hepatitis, B reactivation, hepatitis A or E, drugs, autoimmune flare, Wilson's disease, and many more. Whereas same way, those are extrahepatic or you can say systemic. It can be infection, it can be GI bleed, surgery, post tips, PICD, or sometimes we call it as a cryptogenic. So this is how you can see, as we discussed before, this is all the sterile inflammations. This is all sterile infections where infection is coming to a very small part. So when you go through, this infection leads to the inflammation going through. And little bit difference is the MFLD. Where MFLD, you can say it is MFLD, mass or mass cirrhosis. They have multiple hits, you can say. There is a genetic predisposition. Then you can get a modifiable risk factors. These are called the second hit. Then you get an acute insult. This acute insult can be infective or non-infective as we discussed. This leads to the persistent the signal cascade like the ACLF1. So here I want to then this genetic cascade is more robust in case of predisposition as far as MFLD is concerned. So to summarize, it is infection and inflammation. Then it is the sterile inflammations, and both combines gives to the ACLF syndrome in a nutshell. So it is ACLF, a state of inflammation, how it is goes through. Once this cascade is started, you can see here, various definitions are here, but it is an acute insult. This leads to a window period which is called as the 7 days period. Then you get SARS, then it develops progressively liver and additional extrahepatic organ failures. Just want to highlight the extrahepatic sets in after the primary, the liver or the disease starts failing. And this is how the sequence is happening over time. If you think of this, it can be acute decomposition or end-stage liver disease, whereas the ACLF by Apostle and Cliff is the same syndrome but catching at a different point of time. You can see here in Apostle, we think that this should starts from here when it is the liver get the first insult, whereas the Cliff or the Western definition, they think that renal parameter is a must. We know it can happen, but it is quite late in the state, and I will clarify in following few slides. So with this, we thought of pathogenesis of ACLF, how it is happening. Now we just need to know how to go for. You can see here, this is a very interesting, the common we can say, it is an acute insult, it is a chronic injury, and this leads to the liver failure, and this can be reversible. So ACLF is syndrome of an acute insult to a chronic liver disease or chronic injury, and the response is liver failure. Just to simplify this is the terminology. So dear friends, you tell me, this is one acute insult which can be hepatic or systemic. Then it happens to what? It happens to chronic disease. It can be a non-cirrhotic compensated decompensated prior recompensation or ACLD. So this is whole basket is the chronic liver disease where we get an acute insult. This leads to the liver failure, which is liver at the core. It can be jaundice or INR. The first has with the apostle considers or ascites and hepatic encephalopathy. And extrahepatic are the renal, circulatory, and the respiratory failures are there. So ACLF happens with an acute insult. It can be hepatic or systemic. It can be to a susceptible background leading to the liver failure. So this is the definition and suggestions from the apostle consensus is that when you get an acute insult to a CLD compensated decompensated cirrhosis, if you consider these peoples, this first is ALF, everybody is having no confusion. Decompensated cirrhosis, even they get an worsening of failures, they should not be considered as a part because it's clearly a distinct entity should remain. The chronic liver disease, which leads to acute insult, develops a liver failure. And a compensated cirrhosis with an acute insult, they develop syndrome. This is the group which consider this ARC-ACLF. So ARC-ACLF is a pristine entity. It is a well-defined spectrum across the whole CLD, because when you define for the non-cirrhotic or compensated as the first presentation as liver failure, you can identify very selected group just to prevent the ambiguity of the definitions. But when you consider this cliff, it considers all patients, that is compensated, decompensated, acute insult, hepatic, non-hepatic. So it becomes a very heterogeneous group. And whereas Naxalt, which considers patients only with infection related or with two or more organ failures. So this is the definitions. I don't want to go details. I think everyone is aware of these definitions. But what I want to highlight that this ESL, Nextel, or the Apostle now the curse has come up. Sorry, I have not included here. This is the ARC database has now expanded to 8,600 patients who have been analyzed, and 10,000 is the database above. We consider both non-cirrhotic and cirrhotic, but the insult is always directed to the liver. A person who having a ascites, SBP, and AKI with a shock, if you consider it becomes ACLF, is unlikely because he's not bilirubin, his INR is not high. And we need that liver dysfunction should be at the core. So this is what I want to highlight. And with summary, so these are the two definitions which commonly consider. It is an acute hepatic insult with jaundice and coagulopathy happening in a period of 4 weeks in a patient who is previously diagnosed or undiagnosed, and it should be an index presentation and associated with a high mortality. Whereas Hazelcliff is acute deterioration of any person chronic liver disease, mostly cirrhotics, and they may have a precipitated event, but it is not identified in nearly 40% cases, and they should be having organ failure is a must, and this organ failure is mostly extrahepatic and hepatic. So when you apart from this, the final definition is this: a distinct entity of liver failure with or without extrahepatic organ failure and having a high short-term mortality. So this is SLF. I think dark clouds will be cleared very soon. Just I want to say, if we got the definitions, how and what are the way forwards? You can see here, friends. So few suggestions from my end. SLF is a syndrome. It is different patient, and we have to understand the east and west. There is no country definitions because we have to understand the patient and the disease, not the definition. So how we can go through? So this is a very interesting analysis from West. They have taken all the published definitions of SLF as a meta-analysis. You can see here the SLF definition and prevalence is high in Asia. You can see if in 1,84,000 patients from the all global published studies, the East Asia, South Asia. So this is what it is close to coming around overall is 35, but when it comes to the Asia, it is coming to 60. So why this? This SLF definition, are the patients are more prevalent in Asia Pacific? Certainly not. Then you can see this is a classification for the chronic injury and acute injury. When you consider chronic injuries, most commonly it coming as the alcohol and viral, where the NAS or cryptogenic has been excluded, but still it shows that the disease is can see globally it is alcohol is 45, and in Asia you can see 38, 41. It is matching this cohort rather than the B as the major predominant cause. And the global tendency is 29, and it is also having the same, except the East Asia, which is having high viral loads. And when come to the acute insult, you can see here the alcohol, viral infection, GI bleed, and the others. This infection as an entity, you can see is more high in European continents. And you can see GI bleed is more than the Asian continents. This suggests that when we included the extra hepatic, which can be complication like infection or GI bleed, then we are getting a very high number. So this is what we need to know whether the SLF is a hepatic or is a systemic. So that's why they are the different group of the patients, I can say. This is interesting from the ESL consensus, where they have shown the SLF precipitants. You can see here the infection is a major cause. Any cirrhotic patient can have infection. If you consider infection as a precipitant, it should satisfy the liver failure. Only having a pneumonia leading to AKI, if you want to tell them as a SLF, it is a big no. I think everyone in your practice can see a person of having cirrhosis who is otherwise decompensated, he develops pneumonia, gets AKI, then is becoming an ACLF, which is big. So that is why we have to think how we should come to harmonize the global definitions. And similarly, very interesting is here this data of 1 lakh meta-analysis. You can see the organ failures. The brain, which you can K as part of liver, coagulation can be part of liver. Whereas you can see circulatory and respiratory. These definitions you can see here, the complications are mostly confined towards the Western groups, and this coagulation and the liver is integral part in Asian parts. That means liver and coagulation, the which are considered jaundice and the bilirubin and the INR is more prevalent in Asian part, whereas others in the global part. So this is also shows that it is organ failure is to be differently defined hepatic versus extrahepatic. So first we thought these are the different patients that need a different way approach. And if you want to them consider, this should be second solution is SLF. Unlike decompensed cirrhosis, we should include recovery, recompensation, or a reversal. So how to justify C? If a person comes to you, he is having ALF, the recovery is close to 60%, and this recovery is complete with improvement in management practice. Even in SLF, I think all you have the practical experience. These patients close 50% recover well, but we won't have any longitudinal data how they're being completely recovered. No, but definitely SLF nearly half get recovery from the illness. So when you consider this apostle group, you just see you have tried treatment, specific therapy, or the liver transplant. Some will recovery without having a transplant with this native liver, and the sequence can become either normal, fibrosis, compensated, decompensated. So if ALF, it can become normal. We don't know whether it becomes normal in ACLF or no, particularly autoimmune hepatitis get treated, but definitely they can, if not getting transplant, if they recover, they will have either fibrosis or they become compensated or they remain in decompensated. That shows that in ACLF, nearly 50% what we say has some course of recovery or some point of reversal. And this is also very well studied. Alcoholic hepatitis in ACLF, you give treatment with steroids, you know the results by day 7. If reactivation, you have given nukes, 2 weeks, 2 log reductions, you can get that they likely to recover. Autoimmune flare, you give steroids, MELD score is below 24, then they are likely to respond. If daily, they likely respond the MELD or R score. So this is what we need to know how this in long term go for. So this reversal concept is very much known in case of autoimmune hepatitis. I think you may have the practical experience, and they can become F1, F3, if SLF, they become non-cirrhotic. If F4, they get recovery, and predictors are when they are having low HCPG or fibrosis F3 or F4 without decompensation. Similarly, in alcohol, this is all data from the West, where they have shown that delisting is happening in a group of patients and close to 9%. This delisting is because of they getting recovery and they become stable or treatment or long-term follow-up with abstinence. And this is, we can see here, the number of patients who are big reversal are group is large number of alcoholic and hep C, and is a MELD score, baseline is a predominant determinant. So that means a reversal is a terminology which is visible globally if we identify them properly. And similarly, hepatitis B, you can see this is a very interesting curve. If child A, the recovery is much more than child B and C. So they can get reversal, and I hope you have seen practice too. So the reversal is unique for a selected group. ALF, you can get a complete recovery. In case SLF, you may get some recovery. But once it is a decompensated cirrhosis, you won't get recovery. It is remain stable or get fluctuating, get stable, get fluctuating, but overall the hepatic reserve goes down, and in long term that develops liver failure, need liver transplant, multi-organ failure. So this is how a person of decompensated cirrhosis, if he club with ACLF, it becomes a separate entity, and hence we need a clarity for these considerations. So this is what already I have shown out. So this is the second suggestion, that we should think of reversal as a part. And third, SLF is not merely a decompensation with organ failure leading to mortality or a transplant. That means if you define someone SLF, either they have to go for the transplant or they will die. but this is not the disease, because we have discussed recently there is reversal, transplant free survival is happening nearly 50% of patients. So acute decompensation is large ascites, hepatic encephalopathy, GI bleed and infection, and jaundice was before, and now it has been removed by the Bavin, which was there before. So I'm worried the jaundice is how to be excluded from these definitions. If you think of chronology in your practice, a person comes to with any problem. If jaundice develop any point of time, they will have natural history is different. A person having ascites refractory once develop jaundice and coagulopathy, he is unlikely to recover. But wherever a person comes with jaundice and high NR, like alcoholic hepatitis, they have a chance of fair recovery. That means the chronology of events, if jaundice is first, followed by INR or ascites hepatic encephalopathy, the chance of recovery with medications may be better. But if it is initially ascites, then the recovery is going to be difficult and troublesome, and these patients need transplant or they have a end-stage liver disease care. And this is rightly said here. You can see this is called the pattern. We have seen first the chronology, and you will consider the patterns. If ALF, this is high acuity, high emergency to be treated. If it is ACLF, it is in between. If it is chronically decompensated, you have a long window period. You can consider these patients to be stable. We can manage well. You can put them in the wait listing, or we can think of a time for the transplant. But if ACLF, we have a very short window period. That means it is acuity is high and the seriousness is moderate. That means it is a separate entity which needs consideration. Dear friends, this is a scores from the West where they define mostly the futility. That is, 4 organ failure, clips skip more than 64, lasting 4 days. These patients are not likely to recover. And this is, if you consider SLF 1, 2, 3, that means you are going on adding the additional organ failures. But if you think of a combination of therapy, apostle SLF is pristine entity where it gives a scope for reversal or recovery, or helps you who goes to be treated or transplanted. If you some cliff or an accident, I am not telling no. It is just to suggest that how they can be prioritized for the liver transplant, or how you can define the futility. That means it is quite late and the advanced stages. So next suggestion is SLF should be a index 1. It should be a unique entity and it should be homogeneous. You can see SLF, if is cirrhosis or no cirrhosis, the recovery is better. You can see non-cirrhotics, even they have complex recovery is good than the cirrhotics. And this is the ASLD guideline published last year. They have taken these concepts too. You can see it included chronic liver disease, compensated cirrhosis, decompensed cirrhosis, which was initially not there. That means non-cirrhosis also behave like SLF, and they get hepatic and extrahepatic organ failures. They may recover, they may be irreversible, and this curve goes down from reversible to irreversible. So this is what the apostle has proposed for the long time. Now we think the globe is merging in recent ways. And this is the SLA consensus from ESL, where the spectrum is considered to have a no SCLF, which is stable decompensation, which becomes unstable decompensation, then pre-SLF, then SLF grade 1 to 3. That means it's a continuous spectrum. So dear friends, if you think of this definition, any patient of your cirrhosis in ICU is going to have SCLF. That means SCLF is no more a definition. SCLF becomes a natural history component. Any patient before dying, he needs ventilator, he needs organ failure to support with dialysis, and he needs a to be avian brain failure. So if you consider as this organ failure as a complication and progresses like this, no SLF, pre-SLF, SLF, that means every patient is SLF at that terminal end stage. But this is not the definition. So dear friends, you think rationally, think of SLF as a unique entity is not a end stage complication for all liver patient cirrhosis. And this has been now the last year ASLD has suggested that these patients are critical ill cirrhosis or ACLF. They need risk assessment by different methods where they have included the R score also in ASLD, and they have considered this to consider clip score or increasing arc, NACSELD or the organ failures to be considered for treatment, transplant, or to go for the hospice cares. So my final conclusion slides to be, we need a definition which consider the essential criteria. What should be the essential criteria for a diagnosis? Liver should be core or not? I think you people are just to judge. This is just I want to hit the nail. These are the points to be discussed. Extrahepatic organ failure should be considered at the beginning, or it should become as a complication once the liver failure starts. And what should be the timing? And sepsis should be considered as a precipitant or no. Sepsis should be considered only when it behaves as per the ACLF syndrome. That means sepsis leading to the liver failure followed by the extrahepatic organ failures, not the sepsis per se with renal failure or circular should be considered. And decompensated cirrhosis should be considered or no, because with consideration of decompensated cirrhosis, we get a huge overlap of the organ failures and syndrome becomes more heterogeneous. So for this, we need global registry. We need combined hand for everyone. We need contribution and collaborative participation, and we need more perspective of study across the globe so that we know the patient and how to go for. And this is what we thought of the convergence, that is all the leading societies of the globe connect, collaborate, and contribute. And for this, tomorrow, on 29th, we have the ACLF consensus here in room number 558, this fifth floor. Please join everyone. So this time the ACLF is getting the sixth consensus update, and I am the organizing secretary for that. And the theme here is ACLF towards a global consensus. So dear friends, please join and please help removing these controversy definitions. With this, I want to say thanks, and I am open for any discussion. Yeah. Okay, I think we'll go for the next session by Professor Tira.
Good morning, ladies and gentlemen. Thirdly, I would like to thank Professor Shima and the APARSO Organizing Committee for their kind invitation. It's my privilege to participate in this APARSO meeting in ancient and beautiful city, Kyoto. May I have my PowerPoint, please? My part today, I'm going to talking about prognostic predictor in patients with acute or chronic liver failure. And here is my disclosure. As you heard from Professor Asok, that ACLF is an acute decompensation of chronic liver disease with or without cirrhosis, characterized by development of organ failure with high short-term mortality. However, even this ACLF been recognized for over a decade, but they still have some different definition, as you heard from Professor Asok. I just like to draw your attention to see some point that quite different before we go into prognostic factor, because it's also quite different when you based on different characteristics of patient. As you can see that APARSO mainly it focus on intrahepatic injury. Comparing with ESO and North American Society, they also try to focus on both intra and extrahepatic insult. And for liver failure, APARSO make a liver as a core of organ system. It will be develop jaundice and coagulopathy and complicated within 4 weeks by ascites and encephalopathy. But ESO, they also look at both hepatic and ectatic organ, focus on sick organ failure. North America is more severe form when they classify organ failure. Either mean kidney require renal replacement therapy, or hepatic encephalopathy had to be severe hepatic encephalopathy, or those who have respiratory problem require ventilation support. And for organ failure, you can see liver APARSO defined as a bilirubin more than or equal 5 milligram per deciliter, and INR 1.5. But for ESO, they look more bilirubin greater than 12 milligram per deciliter. And APARSO look at a major for organ failure, as well as North American also look for organ failure, but ESO look at the 6 organ failure. You can see there's some fight a little bit different in definition, and that's why they study if you have one patient 100 patients with acute decompensation, you go on this three definition, you can see different percentage in the proportion of those who actually been diagnosed ACLF according to different definitions. However, how often we see ACLF, and this you can see, we can see that about 1/4 or up to 30% of patients admitted with cirrhosis have ACLF. And another study from China, they look at the patient who underwent liver transplantation. They see that 41% of those patients who underwent liver transplantation have ACLF according to the ESO criteria. Participant, it can be both intrahepatic and extrahepatic insult, but also we focus on mainly intrahepatic insult, and it can be include bacterial infection, alcohol hepatitis, hepatitis B activation, or however, 40% of the patient with ACLF could not identify the precipitant factor. And as mentioned earlier, that this syndrome associated with a high short-term mortality. You can look on it one study, you can see that 28-day mortality is up to almost 60%, it's about 58%, and 90 mortality is about 64%, almost 2/3. However, from this study, if you look carefully, you can see that 46% of the patients have ACLF grade 3 with associated with a higher mortality at day 3 to 7 of ICU in admissions. My part today going to talk about prediction and prognosis, because the accuracy and sensitivity of predicting score can guide the patient to make a decision intensive care strategy and also predict the outcome in patient with acute on chronic liver failure. Here I summarize all the predictive and prognostic score developed by different consortium. You see APASO, you see ESO, you see North America, and this one is the Chinese group on study of severe hepatitis, mainly focused on reactivation of hepatitis B. You can see all the society develop different predicting score, and you can see the formula. We did not go into detail, we had time limitation, but you can go on website and you can get this formula and you just put the number on. You get the score and you get the prediction. This is mainly about mortality and outcome of patient with ACLF. But the last one is about predicting score. You predict who going to likely develop ACLF in near future, which we will touch on at the end. Let's start from the APASO ACLF Research Consortium score. You can see they put score depend on the total bilirubin, hepatic encephalopathy grade, and INR, and lactate and creatinine. So mainly focus on 3 or 4 organ score. And if you combine the score 5 to 7, we define as grade 1 ACLF, and 8 to 10 will be grade 2, 11, 15 will be grade 3 respectively. How about this score predict the outcome? You can see that the higher grade of our score associated with a high rate of 28-day mortality. You can see only 12.7% 28-day mortality when the patient have grade 1, that's score below 7, but it's up to 85.9% if the patient have a score grade 3 defined by score above 11 to 15, and therefore the patient who have a grade 3 persistent until day 7 after ICU admission had a very high mortality and require liver transplantation early. So let's go to the ESO criteria. They develop a CUP score mainly based on organ failure, and they look at the 6 organs: liver, kidney, brain, coagulation, circulation, and respiration. And you can see the score according to the number of different 6 organs. And then we touch on the CUP ACLF score, because CUP organ failure score is a part of ACLF, because ACLF score define that they know that age of the patient and also inflammatory response defined as white blood cell count is very important in the part of pathogenesis and prognosis. Therefore, they put the formula of the strip organ failure and add 8 and white by cell, and this formula to call CRIP ACLF score. And did the prognosis of CRIP ACLF score, you can see this is the derivation set, and you can see comparing between the predicted score and also observation. You can see that CRIP ACLF have very good prediction of a 28-day mortality and can very similar to the observed patient. And you can see higher CRIP ACLF score is associated with a higher 28-day mortality. It up to around 70% both in observed patient and in predicted according to the score when ACLF score greater than 58. And lead validation set also confirm the accuracy and predicting value of the CRIP ACLF among both observed and also predicted score. Let me go to the important landmark. This is CRIP ACLF. They look at the patient with the grade 3 ACLF with the CRIP ACLF score greater than 70 associated with a high mortality. That you can see that 94.7% positive predictive value to predict the patient more likely to die within 28 days and with only less than 7% negative predictive value. They put in the summary when they look at the patient with ACLF grade 3, that means at least 3 organ failure, and also combination with the CRIP ACLF greater than 70. You can see those who have CRIP ACLF greater than 70 had really low survival compared between those who less than 70. And this another study look at ACLF grade 3 with the CRIP ACLF. You can see that score greater than 7 associated with high mortality. Actually, in this one, everyone died before 28 days. That means almost 100% 28-day mortality. They look on this one because they're going to talk about futility of liver transplantation. We know that liver transplantation, it benefits for both ACLF grade 2 and grade 3. They can improve either short-term survival and 1-year survival post-transplantation better than those without liver transplantation. However, as you know that due to the shortage of the donor organ and also particularly in our region, we still lack of liver donor. And also we know that ACLF grade 3 is associated with the higher post-transplantation complication and lower post-transplantation survival. So we have to balance between shall we give to save the patient or shall we spare the donor to those whom will be likely benefit from organ transplantations. That's why the futility score. Look at this one again. ACLF grade 3 with the CRIP ACLF score greater than 7. You can see that 28-day mortality is about almost 100%, and this 100% specificity. So the patient, you have to consider, shall we give them liver transplantation or shall we just leave twice supportive care and give the donor organ to the other patients? So Gustock developed this beautiful study. They want to see if you just assess the patient at the first time when they come to ICU or we do dynamic every day. They found that look at if the patient have at least 4 organ failure. You can see 100% 28-day mortality, and even they assess at day 3 or 7 also predict 90-day 100 mortality. For CRIP C ACLF, if they look at the patient who have a CRIP more than 64 at day 3 to day 7 of ICU admission, it also predict 100% mortality. Therefore, from this futility of liver transplantation, they found that if the patient ACLF with at least 4 organ score and CRIP ACLF more than 4 until day 3 to 7 of ICU admission, we should not consider liver transplantation among this patient because it might not benefit comparing the shortage of the organ. However, another group say that we should decide futility liver transplantation should be case by case consideration. And therefore, they develop another score, and this one developed they call transplantation ACLF 3 model score by adding 8 patient greater than 53 years old, and also arterial lactate greater than 4, and mechanical ventilator, and that oxygen saturation, also leukocyte count. They found that if the patient have at least 3 parameter, one score for each this parameter, have at least 3, you can see only 9% have 1 year survival after liver transplantation. So maybe it's not worthwhile to do transplantation and expect only 9% 1 year post-transplant survival. So this one, they consider if the patient have ACLF grade 3 with high ACLF score in combination with TAM, at least more than 2, they will not consider liver transplantation. They might even move the patient from ICU to have only supportive care in out of ICU patient. This study in Thailand, we did a multi-center study in Thailand. We can see that we look at 301 acute decompensated patient without ACLF, and also comparing with the 301 patient with ACLF. You can see that the first thing, the patient with ACLF had a higher mortality, either 30-day or 90-day, than those who just acute decompensation. That's why Professor So tried to differentiate acute decompensation from ACLF, because ACLF had a higher mortality and poorer prognosis. And among the patients with ACLF, you can see the higher ACLF score, followed by ESO-CRIP score. You can see that higher grade of ACLF had a higher mortality. It up to over 75% and up to 85% with 30-day and 90-day mortality if the patient have ACLF grade 3 according to ESO criteria. And they put in another way to look at the patient with acute decompensation without ACLF had the best prognosis. When you compare with the ACLF grade 1, 2, and 3, the worst prognosis see the patient with ACLF grade 3. So in Thailand study, we compare this predicting score between CRIP ACLF compared with the male score, male sodium, and Child-Pugh score. You can see that by area under the curve, CRIP ACLF provide the best predictor according to the area under the curve, either for 28-day mortality or 90-day mortality. And this study from Canonic study also confirmed that looking at ACLF patient, the CRIP ACLF had highest area under the curve for predicting 28-day or 90-day mortality, same as our Thailand study. So about infection, we know that infection is a very common among ACLF patients. It also associates the poorer outcome. Look at this one. The patient with infection and no infection, if the patient also have ACLF, you can see according to North American Consortium, infection among ACLF had the poorer prognosis. You can see that 90 days survival is just about 59%, comparing with those without ACLF. And those with ACLF with infection, you can see also decline of survival, and also the patient with the grade 4 or 4 organ failure with infection, you can see only 24% survive at 30 days after admission. I try to compare between different scores in terms of sensitivity and specificity and predicting the outcome. You can see, actually, when you look at the study for 30 days, they're not much different. They provide quite good area under the curve. And for 90 days, we have the data from North American Society, and also ESO also have quite good area under the curve for predicting 90 days. Even different score, different definition, but they provide a similar predicting value. I go to the last part about acute kidney injury. As we know that acute kidney injury is also major organ failure among ACLF patients. And if you look at this one, the patient with acute decompensation and no ACLF, and this ACLF patient, you can see firstly, patient with ACLF had a significant higher incidence of acute kidney injury, 92%, comparing with those with acute decompensation, but without ACLF, only 36%. And most of the patients can occur in even perfect normal kidney, and about 1/5 in chronic kidney disease. And you can see chronic kidney disease alone, quite uncommon in acute decompensation or ACLF patient. Did look at mortality. You can see the patient, if they had acute kidney injury in ACLF patient, they had the worst prognosis. You can see that, the green color. Then those without acute kidney injury or with acute kidney injury, but just in acute decompensation without ACLF. And you see the number of the population, quite good number. And this also look at the male sodium. You can see the patient with ACLF with acute kidney injury increase mortality over the time that you see the increase the score of male sodium. So when they put the independent predictor factor of 3-month survival in the patient ACLF with acute kidney injury, you can see the model 1, you can see that urine enground, male sodium, and ACLF is the significant independent predictor of 3-month survival. And also, if they look at the model 2, acute the male sodium, again, urine engrow, serum bilirubin, and INR, and percent of ACLF are the independent predictor of 3-month survival. I come to the last part of predictive score. Did ACLF consortium develop a predictive score? You can see when the patient come to admit to your hospital with acute decompensated liver disease, you can see you use the KIP score definition to define whether the patient have ACLF or not. If they have ACLF, you just go along the KIP ACLF score. If not, we call them acute decompensation without ACLF. We follow the KIP acute decompensation score. If the score at least equal or greater than 60, you can see 3-month mortality is 30%. It's higher than with the low risk population. And this also predict this patient with acute decompensation even without ACLF. But they predict with this score that they will develop ACLF full soon, higher than those the low risk population. So it might move to the left pathway that become ACLF later on. Mr. Chairman, ladies and gentlemen, this is my conclusion. ACLF is leading condition with acute decompensation of chronic liver disease characterized by organ failure with high short-term mortality. Due to the different in definition of ACLF among the different society, sometimes it's quite difficult to truly compare the accuracy and quality of different scoring system. But I show you at the last slide that even it's different, but it have some similar and go in the same directions. The scoring of prognostic predictor is important to guide the physician to know the prognosis of their patient and guide them to provide the proper management strategy. Higher grade with higher number of organ failure indicate a really poor prognosis and high 28-day mortality, so early transplantation should be considered. Nevertheless, the ACLF grade 3 with ACLF score more than 70 is associated with a high mortality, and some people use it as a fertility for liver transplantation. However, to use this as the fertility liver transplantation should be considered case-by-case decision, and you might add some scores such as comorbidity or transplantation ACLF model score more than 3 should be another consideration. Therefore, the fertility of liver transplantation among ACLF patients urgently unmet medical need. We need to clarify and maybe work together with two society to develop a really precisely and accuracy fertility of liver transplantation. And I thank you for your attention.
Hello, good morning. I'm Manuel Mendizabal from Argentina. Congratulations for your presentation, Dr. Piravitsu and Dr. Shuduri. Sorry, I probably misspelled your last names. Anyhow, I have a comment and a question. So my comment is that so far we have 3 different ACLF scores. I find them quite difficult to use one score for everybody. In Asia, you have very different triggers for acute decompensations like Hep B, Hep A, herbal medications. So in a way, I believe that we need to agree which score to use or to validate in each region. So I don't see the point at what in the future to have a unique score. That would be really hard to achieve. And my question is,
Can I respond to that? I think
Sure.
I agree with your comment, and that's really good. And you can see clearly we had different definition and different score. You should, if I were you, I would use the score according to the patient characteristic when they fulfill into the criteria. And if you look at the study, 100 patients with acute compensation, and you go by different treatment, you will see different patients fall into different criteria of ACLF. So therefore, scoring system should be according to the characteristic of patient with their fulfill for the definition. And however, I show you some slide that even they have different scoring system, but the prediction of 28-day and 90-day mortality is quite similar. It shows you the similar predictive value. And I totally agree with you that, and Professor So as well. In the future, all the big three society should work together, collaborate together in order to develop the unique and beautiful definition together and develop a scoring system. And that will be easier for the physician to use and follow that score.
that would be really nice. So my question is, you presented a slide regarding the AARC score, and that we should consider transplantation when the patient reaches grade 3 at the 7th day. Wouldn't that be too late for transplantation? I haven't seen any study like the one of Gustad showing the CLIF criteria and the outcomes according to the grade once where they were transplanted. I don't know what happens with the ARC score once you
think-
transplant those guys.
Actually, when you look about transplantation, ARC either grade 2 or grade 3 associated with the 28-day and 90-day mortality. So they should be considered transplantation. And we look at the outcome. When you compare with the either ART or CLIP score, grade 2, grade 3 patient, comparing those with liver transplantation and without liver transplantation, they found that liver transplantation have better significant either 6 months or 1 year survival. And sometimes it's not different from the patient without ACLF. Okay. However, most of the patient with the grade 3 or grade 2 agree with you that sometimes they had some condition that contraindicate liver transplantation, like still on liver renal replacement therapy, on respirator with severe hypoxemia, and also have infection. So they're not suitable for liver transplantation. So we had to select some patient, and that's why some patients they die on the waiting list due to the contraindication and another comorbidity and complication. However, even the transplantation for grade 2 and grade 3 patients provide the better survival than those without liver transplantation. But when you look at carefully, those who transplantation for grade 3 has significantly higher complication. They require renal replacement therapy. They require intensive care stay, longer hospital stay, and also infectious complication. Therefore, it might compromise the outcome. Combining together and in situation of shortage of donor, that's why they try to develop the fertility of liver transplant to pick up those who should be undergo liver transplantation and get the benefit. That's why they develop ACLF CLIP score more than 70 and also develop the TAM score, that transplantations ACLF model. However, they try to do the right way, but we still not get that point. We still try to provide liver transplantation early for grade 2 and grade 3 and try to save the organ to the patient who had the better outcome post-transplant. As I show you that if the patient have TAM score more than 3, you can see only 9% patients survive 1 year after liver transplantation. So we cannot use this score just to see one patient in front of you. We should consider case by case analysis and try to develop. I think three society maybe in the future develop a very good fertility of liver transplantation score.
Thank you.
Yeah. Thank you, Professor Tira. You can join the dais here, Professor Tira, please. We can get the video lecture Professor Sarin. Yeah. Yeah, you can.
Greetings from the Institute of Liver and Biliary Sciences. I have nothing to disclose. I would try and cover new management options for acute and chronic liver failure. The definition has been very well covered and discussed by Dr. Ashok. I'll just briefly touch on it 2 points. ACLF is a group of patients who present as acute hepatic insult and liver failure, but have an underlying cirrhosis. The acute insult can be ethanol, Hep B, viral Hep, autoimmune hepatitis, DILI, Wilson's, or unknown. And the patient may have a chronic liver disease advanced or has cirrhosis. It has a high short-term mortality, but in a proportion, the liver failure defined by jaundice of more than 5 and INR of more than 1.5 with ascites and HE to recover. So there is a component of reversibility inbuilt into the definition. The Japanese, your country, defines ACLF also nearly similarly. A deterioration of liver function in cirrhosis with Child-Pugh score of 5 to 9. You exclude decompensated cirrhosis and include patients with a bilirubin of 5 or more and with an INR which is 1.5 or more and is caused by severe liver damage and it develops within 28 days. Such patients have high mortality. Recently, a Mexican Association of Hepatology also gave a similar definition where acute hepatic decompensation occurred and it resulted in liver failure. So liver failure remains the core of definition of ACLF. Patients who have decompensated cirrhosis, they get further decompensation and may have sepsis, shock, bleed, AKI, HE, or organ failure. They have a different course of the disease. Patients who have chronic liver disease, F3, F4 with an acute insult, or those with compensated cirrhosis who get decompensation specifically with liver failure with a high bilirubin of more than 5 and INR and develop ascites is the APSL phenotype. This is only one phenotype of decompensation, while patients who present with bleed, HE, ascites, AKI, sepsis, or combinations, or have decompensated cirrhosis, they have organ failures, you actually have 27 phenotypes. And you may not actually have a patient who has ever got jaundice. So this is a pure phenotype and this is a heterogeneous. Moreover, a patient who has got cirrhosis but has no jaundice or liver failure and he gets pneumonia, what will you call him? Like a patient with chronic pancreatitis, he gets pneumonia. Will you call it acute on chronic pancreatitis? If no, then why do you call a patient who has got cirrhosis but no liver failure as ACLF? So APSL and ARC, the APSL ACLF Research Consortium gives you a clear phenotype of patients, while EASL or CLIF give you heterogeneous phenotypes. Now I'll try and cover various new management options. The first being patients who are on statins. Compared with those who did not have statins, there was a reduction in the incidence of development of ACLF by 38%. However, in this large study of 84,000 patients, statin use was associated with more likelihood of developing kidney and circulatory failure. So overall, whether statins are protective or not, probably they are, but one should be careful to give this a term. Risk of development of ACLF in a patient after medical interventions, and can you prevent them? So ERCP can precipitate in cirrhosis 11% of ACLF. Maybe when you are doing patients with high MELD. Tips can cause 3% of the patients to develop liver failure, hyperbilirubinemia, and surgery, especially abdominal, can lead to development of liver failure, and therefore one should preemptively either prevent or protect your patients. You can treat your patients by sublimating the acute insult. In a patient with hepatitis B, giving tenofovir or entecavir and achieving 2-log reduction in DNA in 2 weeks can improve the outcome. Similarly, in patients with alcohol and AIH, patients who have got severe alcohol-associated hepatitis and ascites, and they have jaundice, such patients are not actually included in most of the trials. Patients who have such a profile, when they were treated with prednisolone compared to fecal microbial transplant, there was a benefit of FMT over prednisolone as far as 90-day and 360-day survivals were concerned. So FMT is a good modality of treating patients with SAHF and ascites. When you give steroids in these patients, you have many limitations. First, patients of ACLF and alcohol, only 30% are eligible. Others have infections or other complications. The group of people who are eligible, of them only 44% are responding. In nutshell, only about 12 to 15% of patients with alcohol ACLF actually get benefit. Who gets the benefit? Let's decide. Patients who have got an ARC score of more than 10, in them the response is poor. So if the ARC is 11, 12, 13, the responsiveness to steroid decreases. If the ARC is lower, the responsiveness chances increase. Similarly, mortality. If patient has an ARC of 11, 12, or 13, the mortality increases. Hence, in a group of ACLF due to alcohol, treat only up to ARC 10. What is ARC score? Just to remind you, it has 4 liver-related parameters: bilirubin, a score of 3 when bilirubin is about 22, HE, INR, lactate, and creatinine. These 4 are related with a maximum score of 15. An ARC-ACLF grade, 1 is 5 to 7, 2 is 8 to 10, 3 is 11 to 15. So ARC grade 3 is a group of patients who may not respond to steroids. How do you treat severe autoimmune hepatitis? If the MELD is less than 25, these patients can be benefited with the steroids. But above that, it is either liver transplant or maybe bridge therapies. The nutrition is a major challenge. Can you give a patient who has a high bilirubin IV lipid emulsions? And this was tried a few years ago by Dr. Anand. High MELD, high bilirubin, 250 ml of IV soybean lipid emulsion was given, giving 500 calories per day for 3 days. There were no adverse events. More importantly, the negative nitrogen balance of -3 at the end of 3 days could be converted into positive nitrogen balance, means the patients are having good energy and the nitrogen excretion decreased, means these calories were utilized. Patients with ACLF have ascites and also have acute portal hypertension. This is because there is cell death, cytokinemia, stellate cell activation, endothelial dysfunction, impaired vascular relaxation, and all these are primarily because of high bilirubin and bile acids, which are hugely vasodilatory and reduce mean arterial pressure. So let's take a patient with cirrhosis who already has raised portal pressure. When ACLF acute insult occurs, there is a further rise, let's say from 12 to 16 or 18, rise in portal pressure in a short period. Because of this, there is a rapid development of ascites, risk of hepatorenal syndrome, variceal bleed, hepatic encephalopathy. So ACLF is a syndrome of acute portal hypertension in a existing cirrhotic with portal hypertension. Now, if a patient has no varices, this was a group of 126 patients and they had a high mean HVPG at the presentation. But after recovery, HVPG decreased from 15 to 7.2, and those patients where there was no recovery, there was development of 2 grades of varices in 4 weeks' time. To mention this, if the patients are recovering, there is a benefit. So what happens if the portal pressure is high? When you give in such patients with high risk varices who have never bled, carvedilol therapy can help, and the survival at 28 days is superior 89% compared with placebo, which is 75% or so. Moreover, carvedilol decreased the incidence of new onset of AKI and development of spontaneous bacterial peritonitis. So reduction in pressure is helpful. Patients with ACLF, if not managed in time, they may develop acute variceal bleed, and those who have bleed compared to no bleed mortality is high even within a period of 3 weeks' time. Therefore, some people in the West try to do a preemptive tips to prevent development of variceal bleed, and it might improve survival, but more data is needed. Patients with acute portal hypertension in ACLF develop rapidly moderate to severe ascites. And if you tap them, they can develop paracentesis-induced circulatory dysfunction fast because they have high plasma renin activity. In a cirrhotic, it can be up to maybe 10 or so PRA, but in ACLF, 20 and above is high. They have high intra-abdominal pressure, a compartment syndrome, and PICD therefore develops early with small amount of tap, even with 3 to 4, even with 4 liters or so. So modest volume paracentesis, what we call as MVP, is recommended 3 to 4 liters associated with albumin infusion. These patients are also predisposed to high incidence of AKI, and this AKI rapidly develops into maybe a development of chronic kidney disease. How do you manage these patients? Such patients, first you will give volume and then you will provide them with albumin. Generally, people would wait for 48 hours to start terlipressin and see if there is a response or not. And if they do not respond, maybe you will add, consider doing a renal replacement therapy. Only 35% respond. We realized that a delay of 48 to 72 hours may be too much, and we started using early terlipressin at 12 hours. So we give volume resuscitation and albumin, and instead of 48 hours, start terlipressin at 12 hours. And this was presented and now is under press. We would like to say if early terlipressin is given compared to waiting for 48 hours, there is a significant advantage in patients to response to AKI, a significant benefit in these patients. And survival also improved almost to the double. Patients with ACLF are having an immune paralysis because of cell death, intense inflammation, which is the driver for systematic inflammatory response syndrome. Sepsis is a consequence of this ongoing liver failure because neutrophils, monocytes, T cells, and dendritic cells, they get exhausted and response poor. This study, norfloxacin prophylaxis in ACLF, published a few years ago, showed that if you give Norflox, there is a better survival than compared to placebo. And therefore, a patient who has not got infection as yet, you can start Norflox to prevent complications. Patients who are already in SIRS can actually develop sepsis very fast. GCSF can help in two ways. It can mobilize progenitor cells to proliferate in the liver itself and from the bone marrow. The mobilized cells, CD34 positive, will come into the blood and then go to the liver and may help in differentiation of progenitors into mature hepatocytes. So it can help in regeneration. And in this trial, we showed that giving GCSF improves the outcome of patients with ACLF. Another two trials also on patients with alcohol-associated liver disease, it was shown that patients who got GCSF were significantly more survival than in control groups. And GCSF plus N-acetylcysteine was further superior than giving GCSF alone. However, there has been several reports where there has not been much benefit. They are all from Europe. They have used patients who are decompensated advanced liver disease without even jaundice, and 54% of them already have sepsis or AKI. Hence, the European studies have not given any benefit to GCSF therapies. Most therapies are from Asia, where there has been an advantage of using GCSF in patients with ACLF. But the jury is still out. We need to see whether if the patients are very sick, can you give them time by bridge therapies or so. So plasma exchange is a therapeutic plasma exchange is one such modality which helps in detoxification, helps in biosynthesis, and to achieve homeostasis in the liver. And this is a common modality. The second modality which has been used is the dialysis system, Mars, Prometheus, single pass albumin dialysis, and recently DiaLive solution. Since this is new, I'll just briefly tell you in this DiaLive solution, Agrawal et al. Showed that albumin and albumin bound toxins are removed. Water soluble toxins are also removed and endotoxins are absorbed. And once this is done, you add a fresh albumin into these patients. Logically, it seems very interesting. It was done in patients, and what they found was there was an early resolution, but no benefit in patient survival. Another modality of therapy is one, as I told you, single mode artificial liver support. This could be plasma exchange. Or you can have mixed mode artificial liver support, MALS, in which you have hemofiltration, plasma exchange plus hemodiafiltration. And in these patients, if you have multiple modalities combined, there is a better 90-day survival in the multimodality treatment compared to a single modality treatment. Why? It reduces bilirubin as well as bile acids and improves INR. What is the basis of all these therapies, bridge therapies? We recently published that there are several metabolites which are toxic, are produced in patients with ACLF. Compared to single modality or standard medical therapy, when you are using plasma exchange or heme adsorption, very few toxic products actually stay back. Other metabolites which are toxic are removed. And this is the way you see patients who are getting heme adsorption, nearly 80% of the toxic materials have been removed. And when you convert it into clinical outcomes, patients who have got therapeutic plasma exchange versus heme adsorption, the number of patients at day 7 who got organ failure is less, and at day 14 also it is less compared to standard therapy or plasma exchange. So we have benefits of heme adsorption. Also, can you predict at baseline whether my patients will survive? So this new discovery of having high 11-deoxycorticosterone, a compound which is probably the best predictor of mortality in patients. If it is more than it increases the risk 3.2 times of death. And deoxyhydrocortisone conversion to cortisol is abundant, and this feedback loop is also suppressed. So the ACTH keeps getting converted into 11-deoxycorticosterone. I'll summarize now that patients with ACLF, maybe statins can help. Alcohol and drug has to be stopped. Drug-induced ACLF, antivirals, steroids will be of help. ACLF due to alcohol, if ARC is less than or equal to 10, is helpful. Other than that, you may use FMT. High calorie diet, intravenous lipids can help nitrogen balance to improve. Carvedilol may be helpful. Do only small volume or modest volume parasynthesis. Eat early. And using of lactulose, PEGLEC in patients with HE, I did not discuss. For patients with pulmonary, prefer non-invasive ventilation. Coagulopathy, correct by Rotem-based methods. And for shock, first of choice is crystalloid and then albumin if there is a shock. Plasma exchange and use of filters is helpful. Assess your patients by day 4 for transplant. Let me summarize this part. How do you manage a patient with ACLF in 2024? If a patient has a score of more than 10 or a MELD above 30 at day 0 itself, suggest transplant. Otherwise, in these patients, you also try and manage as I showed you just now. Fortunately, if your patient improves by day 4 and ARC score reduces, and in this patient, you may continue doing medical treatment, ACLF probably can be reversed in 60%. However, if the score is increasing from ARC 10 or more, then an emergency transplant has to be done. Or if a patient has come with 2 or more organ failures, stabilized by giving plasma exchange, the artificial liver support stabilized and sent for emergency transplant. But if he is not improving or has a 4 or more organ failures and ARC score is above 13, I think patients probably have to be explained that we will give you supportive therapy and the transplant may not be as successful. Chances of survival will be less than 50%. Thank you for your kind attention. I hope all of you can treat ACLF better than us in this postgraduate course exercise. Thank you all.
Thanks,
Yeah. So Professor Sarin is not here, so me and Professor Tira can take the questions if any.
So it was a very interesting presentation. My point is that many of these therapies, they're really expensive. And from countries where, or regions where I come from, that we do not have so many resources. And I would like to know if there is any cost effectiveness analysis of all these therapies, because it's really very expensive to keep an ACLF patient alive. And once you do, and once you think that you can transplant that patient, perhaps you do, you move forward, and then you lose the patients, the donor, and all the effort and human resources and economic resources. So my question is if there is any analysis regarding cost effectiveness of these therapies.
Yeah, nice question. I think as such hepatology is a costly branch. The hepatology itself, because you think of decompensation cirrhosis, albumin infusion is a backbone for you. Once decompensation ascites, you need albumin, it's too costly. If you think of transplant, it is the only solution for the hepatology. That is too costly also. So ACLF, as rightly said, it needs a transplant. And I am not aware anyone doing transplant in first 7 days. We are discussing a theory that transplant should be done at day 7. It is late. But in my practice, where a transplant center, we do 200 transplants per year. But we are able to do transplant only in 10% of cases of all diagnoses ACLF. And within 7 days, transplant is 1% only. So transplant for ACLF in first week, it is very difficult. It is very theoretical than practical. I think everyone can agree here. So that's why ACLF, once you diagnose them, whether irrespective of any definitions, this disease is too sick, and whatever the treatment you give, the outcome is very poor. So that's why cost effective analysis, I think you have to go for. That's I'm agree for you. But whatever the treatment you take, it will be costly because if you're not treating, the life is going, patient's coming, it is too costly. If you're going for the therapies, the best and guaranteed treatment is transplant. It is too costly. And whatever you go for the treatment, plasma exchange, regenerative therapy, so recovery rate is less than 30%. So you are losing 70%. That's then you are wasting time, wasting resource, and wasting money. So that is also difficult. Hence, ACLF is a group of patients where the treatment is difficult and challenging. Cost effective analysis only help you if you have all the options or you are supported by insurance or the government schemes.
Thank you.
I think for me, cost-effective analysis is quite difficult to do in the very high mortality in very silly ill patient. You got many treatment therapeutic options, and you can see even some the new treatment is still have some controversial issue. For example, GCFF, mainly the benefit you see from the Asian population, but did not confirm in European study, probably because different in the criteria of ACLF. Plasma exchange, yet it can improve hemodynamicity, hepatic encephalopathy, but when you look carefully, it not seemingly improves survival. So altogether, I think I agree with you that it's still difficult to do cost-effective analysis when you deal with a very silly ill and high short-term mortality.
Yeah, please.
Hi, Talal from Prince Alfred Hospital in Sydney, Australia. Thanks very much. They're all very practical talks. My question was around terlipressin, giving it early. So there's a confirmed trial from North America which actually showed poor outcomes in those with a creatinine of over 5 milligrams per deciliter, ACLF3, or MELD of 39. So how does your experience compare in terms of they were at increased risk of fluid overload and respiratory failure and death with those parameters? So I would be anxious to give early terlipressin in ACLF3.
Yeah, I think I will add also the Florence Singh paper. They have showed that there is a respiratory failure also with terlipressin.
Yeah.
So this is there, but I think as you rightly said, creatine more than 5.
Yeah,
Yeah, 4 above, we find little bit hesitant to give them
absolutely.
because if creatine more than 4, mostly they are having some structural disease.
Yeah.
Where their response will be poor. So in that case, what we do, a practical thing I can say, it is a constant infusion where you
Yeah.
can reduce the dose and you can see the response in another 24 hours combined with the albumin. If you are getting response, it is you can continue. If you are getting adverse events, then you have to stop definitely. And if you are not getting response, and you have to also avoid. And third, in ACLF, mostly they are having high bilirubin. It is mostly cholemic nephrosis, where the response will be poor. Sepsis associated response will be poor. So terlipressin is a very narrow window for the group of patients, and we prefer to give NORAD. NORAD will also help.
Thank you.
I think there's no more questions. So this postgraduate course and ACLF we are going to close here. Thanks everyone for being here.
Thank you very much to the lecturers and moderators. Now we will have 20 minutes coffee break.